Hi, I'm Jared Gardner, and we're going to do CPC session 1. I've given you guys some digital slides of cases that I think are really fascinating or difficult or both, and that I've learned a lot from over the years. So this is case 1. It's a 68-year-old female with a dorsal foot nodule that was excised, and you can see that it was a very circumscribed nodule situated in the subcutis. And it has some zones like this that are very pink and collagenized, with bland spindle cells arranged in elongated kind of parallel fascicles. And you can tell that the cells have very wavy kind of ramen noodle shaped or instant noodles, I think maybe they're called in Australia. Someone told me on Twitter. These little fibers, collagen fibers in between the spindle cells. So that's usually a sign when I see spindle cells with no or with either a little bit of blue cytoplasm or indistinct cytoplasm and with wavy collagen fibers in between, that probably we're dealing with something fibroblastic or myofibroblastic. And see there, you can see it again. So that's when you see that, I like to call that the ramen noodle sign or the instant noodle sign, which my former fellow Ed Fulton came up with. So we have these kind of fibroblastic appearing fascicles, very bland. Then over here we have much more cellular blue areas. The nuclei are larger, they're more hyperchromatic, still very uniform and monotonous, really no pleomorphism to speak of at all. And in these areas, you can see that the elongated fascicles are kind of intersecting with each other at sharp angles. And that's a pattern, a subtype of fascicular pattern that we like to call the herringbone pattern. Now, in the olden days, that was kind of synonymous with fibrosarcoma, which is a diagnosis that we don't really ever use by itself anymore in modern soft tissue pathology. Only in very select settings we use that. And we also know that herringbone pattern can be seen in a variety of entities. So I went through that list of entities, which includes malignant peripheral nerve sheath tumor, synovial sarcoma, sometimes melanoma, cellular schwannoma, and I tried to think what this lesion might be. And it was negative, if I recall, it was negative for SOX10 or S100, and a panel of other, keratin was negative. Really, it wasn't positive for anything useful except this is CD34, and you can see it's strong diffuse positive for CD34. But morphologically, I wasn't really sure what to do with it. You might think a little bit of solitary fibrous tumor because we have some dilated kind of staghorn vessels. And solitary fibrous tumor can get fascicles as well. And I can't honestly recall if we tried STAT6 in this case or not. I just remember I did a panel of stains, and I ended up with kind of nothing I could really wrap my head around. Because if we look around the whole periphery of the lesion, it's, again, very circumscribed. There's no trapping of adipose tissue. There's no storiform change. It's really just these fascicles of uniform hyperchromatic spindle cells with occasional mitotic figures. So my best thought was maybe could this be like a weird fibrosarcomatous dermatofibrosarcoma protuberans, DFSP? And the only thing about it is it's on the foot, which is certainly possible to have DFSP on the hands and feet. It's been described in the literature, and I have seen occasional cases in the digits or the hands and feet, but it's certainly not a common sight. And also, most of the time when there is fibrosarcomatous, cellular herringbone pattern DFSP, if you have a big enough sample, you will almost always see some areas of classic conventional storiform fat-trapping DFSP next door to it. But in this case, it looks like pretty much the entire lesion has been shelled out here. And we have a very nicely, pseudo-encapsulated, very well circumscribed lesion with not a hint of anything that looks like DFSP. So I sent this off to my friend Dr. Julia Bridge, who I send most of my soft tissue molecular testing to. Number one, because she is a molecular guru who actually invented and discovered a lot of the fish and other molecular findings that we use and understand about soft tissue tumors, and also because she's a brilliant morphologist as well, and she'll take a look at a case and have some ideas, and sometimes really has guided me in what additional molecular testing I should do in ways that helped me to solve the case. And this is only one of the examples that I will show you today. And we went on to publish this together with some other colleagues. So in any case, what this, I did the fish for collagen 1A1 and PDGFB, and it was negative. And I thought, well, I don't know what else to call this. And Julie said, you know, maybe we should try PDGFD, which is a relatively recently discovered alternate fusion that can be seen in a small subset of DFSPs that lack the traditional collagen 1A1 PDGFB. So I said, well, I guess we should give it a try because otherwise I don't know what to call it. And lo and behold, it was rearranged for PDGFD. So she had a case not long before that of conventional DFSP, and then we had this case, which I call a pure fibrosarcomatous DFSP because of its cellular herringbone fascicles. Even though it's not terribly mitotically active, I certainly thought this fit better for fibrosarcomatous pattern DFSP rather than conventional DFSP. And so we published those two cases together in 2020. And you can go check that out in the literature, I think in the journal Cutaneous Pathology 2020. So I don't have follow-up on this patient yet. I would imagine, I think we recommended a re-excision and just to make sure it was widely clear. And hopefully this patient will have a good outcome because it was small and circumscribed. So a really interesting case because the patient was older than the traditional patient. The anatomic site was unusual, and the classic DFSP features were not there. And then also, usually we talk about fibrosarcomatous DFSP as having the herringbone fascicles and oftentimes loss of CD34. But I think this case highlights to me you don't have to have loss of CD34. To me, that you can have CD34 still in fibrosarcomatous DFSP, although I think it's important to know that when you see a CD34 negativity in DFSP, it tends to be in ones that are cellular herringbone and fibrosarcomatous. Also, sometimes myxoid DFSPs can lose CD34 expression. So I think those are some important caveats to remember. So I thought this was a really fascinating case. And now, you know, in general, I personally feel comfortable diagnosing DFSP on a classic case on H&E with maybe a CD34 and sometimes also an S100 to make sure I'm not getting it confused with a diffuse neurofibroma, which can have fat trapping and a honeycomb pattern. But other than that, I really feel pretty comfortable making a diagnosis of DFSP when it's classic, just on a very basic workup, you know, of those 1 or 2 immunostains, or even just H&E in a classic case. In difficult cases, I will refer to FISH, particularly when I think it's probably not DFSP, like I've got a bland CD34 positive spindle cell tumor that has a little storiform pattern or a little fat trapping, and I think it's probably not DFSP, but I can't see the whole lesion or I'm not sure. Then I'll use FISH for DFSP to make sure I'm not, just to make sure that it's really not. And that way they can manage the patient conservatively and either watch and wait or do a small excision. And then the other time I use FISH is when I'm pretty sure it is DFSP, but I only have a small sample and I can't see the periphery of the lesion. And before I send them to do a big surgical excision or Mohs, I want to be sure. And so those are the kind of times I tend to use molecular, either when I'm pretty sure it is DFSP, but I want to be 100% before doing a big, potentially morbid surgery, or when I'm pretty sure it's not DFSP and I just want to be sure before I leave it alone and have it come back and recur, you know, with the problems for the patient later. So when I do DFSP FISH, I tend to do PDGFB and collagen 1A1, and if that's negative, I like to reflexively go on to do PDGFD now because of these occasional exceptions to the rule. And I suspect that as more and more people start testing for PDGFD, we will see a growing number of these cases reported in the literature. Okay, so case 2 here. This is a shoulder papule in a 30-year-old female, and this was a shave biopsy. And you can see it's a dome-shaped papule. It is filling the superficial dermis and pressed directly against the epidermis overlying it. At the periphery, we can see there's an epithelial collarette around the lesion. The cells form a diffuse sheet, and there are dilated, almost staghorn hemangioparasitic pattern, if you like, kind of vessels, like the pattern that we see in solitary fibrous tumor. And this is just a reminder, this case and the last case, a reminder that you can see staghorn vessels in all sorts of different tumors, not just solitary fibrous tumor, okay? So just remember, it's a useful pattern, but it's seen in a wide range of different entities. So the cells here are kind of interesting. Many of them have this cytoplasmic clear vacuolation with peripheral nuclei that give them a signet ring appearance. And then if you look closer, some also have kind of a vaguely foamy or maybe even granular almost cytoplasm. I think it's more foamy or xanthomatous in this case personally. Occasionally you can see some little pink globules here. I think they are actually red cells, most of them in vascular spaces. But in some areas you could wonder, is this a blister cell like you'd see in an epithelioid hemangioendothelioma? I mean, that could cross your mind potentially. So those are all things that, you could maybe wonder about. The cells are quite bland. I mean, here they really look like a xanthoma, but the distribution of them would be a bit unusual for a xanthoma or xanthelasma. Well, I tell you, when I see, anytime I see a lesion, whether it's epithelioid, spindled, foamy, granular, xanthomatous, if I see a sheet-like nodular proliferation of cells filling the superficial dermis, making a dome-shaped papule with a collarette around it, the first thing I think of is epithelioid fibrous histiocytoma, or an alternative name that had been proposed in the past was epithelioid cell histiocytoma. And these classically are made of epithelioid histiocytes or histiocytoid cells with a collagenous background and this dome-shaped papule, usually with a collarette around it and with dilated vessels. Okay, so when I was in fellowship, these were at the time thought to be a variant of dermatofibroma. And that never sat terribly well with me because, for one thing, they don't really look like a dermatofibroma. They're pushed right against the surface. They have a collarette. They don't have collagen trapping usually. They don't really have any of the features that we typically see in conventional fibrous histiocytoma / dermatofibroma. Also, about half the time they can express EMA, which is something you don't see in traditional conventional dermatofibroma. So I never really liked that explanation. And it turns out a few years later, after I was in practice, there was a paper published that found that a majority of these tumors actually have an ALK gene fusion and ALK expression by immunohistochemistry. So ALK1 is positive in the majority, about 90% almost, of cases of this entity. And here we did ALK, and ALK is positive. Now, it's not a terribly satisfying positivity. It's kind of weak and focal, but really crisp otherwise. It really is a stain that, in my experience, ALK1 usually has very low background staining. So when I see even focal positivity, I would say, well, that's probably real. And in this case, also, the other main thing I might think of in a case like this would be, could it be a melanocytic process, or could it be a xanthoma or a juvenile xanthogranuloma or some other histiocytic process? So that's the kind of differential I often encounter when I am thinking of epithelioid fibrous histiocytoma. And one or two other things which we'll talk about later. I don't want to give away future diagnoses. So in the past, I tolerated this weak, kind of pouchy, unsatisfying ALK1. And then what I discovered a couple years ago is the problem here is the clone. For epithelioid fibrous histiocytoma, and also, in my experience, for ALK-positive melanocytic lesions like ALK-fused Spitz-Nevis and Spitzoid neoplasms, there is a particular clone that I really like, and it's D5F3. ALK1 D5F3 clone will have usually a much stronger and more robust staining in spitzoid lesions and in epithelioid fibrous histiocytoma. So I know my hempath colleagues that have tried using it feel it's too strong and they're not big fans. So I don't know, I'm not a hematopathologist, but I will tell you that for mesenchymal lesions that have ALK and for melanocytic lesions, I love the D5F3 clone. So if you don't have that in your lab, try to get it and compare it to your old ALK clone and see which one you like better. I have no conflict of interest with the company that makes that clone. In fact, I'm not even sure all the companies that do make it, if it's one or more. But in any case, I just really like the clone and it works well. So just a tip. And then that's, to me, what I love about this is these, as far as we know, these are benign epithelioid fibrous histiocytoma. So I love it when you get a weird spindly or epithelioid or histiocytic looking lesion that's a papule in the superficial dermis with a collarette, and you get ALK expression and SOX10's negative, well, you're pretty much done. You're probably dealing with a variant of epithelioid FH. And the last thing I'll leave you with before moving on, I really love this entity because my my concept of what these can look like has greatly expanded over time. I have seen this one, which is signet ring and kind of foamy cell change. I've seen a very granular EFH that really looked almost like granular cell tumor cytologically. I've seen very spindled lesions. I've seen a spindled epithelioid fibrous histiocytoma that had spindled, whirling, swirling, storiform growth that resembled DFSP but was FISH negative and was ALK positive. I've seen a case that looked kind of like a Bednar tumor, which I've not reported yet, but I think I'm going to wait for a little bit more follow-up in that case. So hopefully none of you go out there and find another one of those and scoop me on it. But if you do, that's okay. I'll just publish the second reported example and it'll all be good. So in any case, I have seen ones that have bone formation, chondroblastoma-like areas, which has been reported in the literature in a small series. I've seen ones that are deeper nodules that don't have a collarette. I saw one in the pinky toe that went all the way down and was near the periosteum, and it was ALK positive. So if you see a weird lesion in any of these things and you're not sure what to do with it, try an ALK. And keep that in mind. There's only a handful of other mesenchymal lesions that are ALK expressing, really, a relatively small number, which we don't have time to go into here because I'm already behind time as usual. But in any case, I really like these because they're kind of cool. They have a wide range of features, and they also are benign. And so when you find this diagnosis, you can have a good answer that is solid, and you can tell the treating physician these are benign. Probably don't need to do anything else. My personal view is you can watch and wait on these. You know, it's possible they may occasionally recur in a non-destructive local recurrence manner, which, okay, if it does, then you can re-excise it then. So that's my personal take on these. All right, epithelioid fibrous histiocytoma, in this case with a cool signet ring cell and xanthomatous change. I hope you liked that case. I really did. Now, this is the other case. This is case 3. What's the history here? This was a 30-year-old male with a papule in the trunk. And just so you know, some of these histories have been slightly altered, age, sex, or other things, to protect the privacy of the patients involved. But in this case, one thing that is true and is not at all altered is that this was reportedly previously treated with topical over-the-counter wart medication. So I assume like salicylic acid or something. I don't know for sure. And I think that that's what results in this strange kind of verrucous change on the surface. And clinically, the dermatologist thought that this might be a verruca. And so a shave biopsy was performed. So I remember when I first put this slide down from low power, I thought, I think it's a nevus, right? It kind of looks like an intradermal, maybe congenital pattern nevus, if you like that sort of terminology. And I looked closer and I thought, well, you know, I guess it's a nevus, but it's something about it was kind of weird, right? It's kind of sheet-like, which nevi can, of course, do, particularly those what I call congenital pattern nevi. But the cells were kind of this syncytial sheet. They're bland and histiocytoid. But as I looked around, I did encounter occasional scattered mitoses, which by itself is fine in a nevus. And of course, if it's been traumatized, even more so. But, you know, usually you'll find at least some nesting or some kind of cord-like, you know, trickling growth in between the interstitial collagen at the base. So it just was kind of a little weird. So I did a SOX10 because I thought, well, you know, maybe it's that, or maybe it's like a histiocytic thing. If it is, though, I don't know exactly what to call it. And then the idea of epithelioid fibrous histiocytoma crossed my mind because it's kind of pushed up against the epidermis, and it's superficial, and it's got a bit of a collarette around it. You know, I always have said these were epidermal collarettes, but one of my very brilliant, recently retired colleagues, Bill Tyler, who knows the literature really well, and he always has some paper to bring up to teach me a new point. He brought up that long ago, back when I was, I think, a child still, there was a paper published that proved that this is actually not the epidermis. This is actually adnexa, eccrine ducts that are forming the collarette. And lo and behold, after he brought that paper up, I've started paying more attention. And it turns out that he and those authors were indeed right, that usually there are actually eccrine duct structures there. So if I misspeak and say epidermal collarette, please forgive me, because it's been years of bad habit. But I guess epithelial collarette or adnexal collarette might be a more appropriate term. Okay. So try that out on your friends at your next cocktail party and see what they think about that little pearl of wisdom. This probably explains a lot about my social life. That and the fact that I got three young daughters. Okay. The stains came back and SOX10 was negative here. And I think I did a couple other things. I think keratin was negative, and I also did ALK1. And ALK1 was actually positive here. So I thought, wow, could it be epithelioid fibrous histiocytoma? But there was one other idea that I had, and I had included some stains for that just in case. And I did this stain, which is EMA, epithelial membrane antigen, also known as MUC1, MUC1, and also another tip to try on your friends at the next cocktail party. And then this was S100. Well, good thing I did the SOX10 also, because I might have thought, well, this is a melanocytic lesion. It's S100, nicely positive. And you can see the nice melanocytes and also the Langerhans cells as our internal control there. Beautiful. So the co-expression of EMA and S100 with keratin being negative, that fits very nicely for a kind of esoteric entity called cutaneous syncytial myoepithelioma. And this is an interesting variant of myoepithelioma published by Vicky Joe and colleagues from the Harvard group. And it's very different from the other things in the myoepithelioma and mixed tumor spectrum. It usually makes this syncytial sheet that's pushed up against the epidermis like this, and so it's very superficial, dermally based. It doesn't usually have the cords and chains and nest-like kind of structures that we typically think of in myoepithelioma, perichordoma, mixed tumor spectrum, a family of myoepithelial lesions, okay? But the other thing is that most myoepitheliomas have co-expression of S100 and keratin, pancytokeratin, as well as EMA. But these usually are negative for pankeratin and instead just have EMA and S100. They can occasionally have focal keratin, but usually they're keratin negative. So they're an important variation of myoepithelioma to keep in mind because they break several of the rules. Like other myoepitheliomas, they do often have rearrangement of the Ewing's gene, EWSR1. And remember, Ewing's gene is positive and rearranged or fused in a wide variety of different lesions, both in soft tissue pathology and also in some lesions that are found in the skin. So it's important to remember that a fusion of the Ewing's gene does not always mean Ewing sarcoma. There are many other things that have EWS rearrangement. It is a very promiscuous gene that fuses with all sorts of different partners, okay? So there are a variety of different partners that are known for a regular type of myoepithelioma, the conventional type. And when tested, these cutaneous syncytial myoepitheliomas are EWS rearranged, but were negative for those traditional partners that are seen in other myoepitheliomas. And more recently, it's been discovered, again by I think Dr. Joe and colleagues, that the fusion partner in these, let me see, I've got it pulled up here, make sure I don't tell you wrong, but I think it's PBX3 is the fusion partner. Yeah, EWSR1 PBX3 fusion has been found in the vast majority of tested cases of cutaneous syncytial myoepithelioma. So what to do, though, about the ALK in this case? That's the wrench in the machine here, as I thought, well, I thought I had this good, and it would either be ALK positive, but negative for S100 and EMA, in which case, or a negative for S100, EMA may or may not be positive. And if it were ALK plus or minus EMA, but S100 and SOX negative, then I would have called it epithelioid fibrous histiocytoma. If it was S100 or SOX10 positive, but negative for the other markers, I would have said it's probably a nevus. If it were positive for EMA and S100, but negative for SOX10 and negative for ALK, then I would have said it's a cutaneous syncytial myoepithelioma. So I was a little torn because I've got an overlap of stains that I didn't know what to do with here. So here's how I solved this case. I used FISH, and I fished this for EWSR1, and I also fished it for ALK1 to see which of these genes is fused, if one or both. And what happened was it was EWS rearranged, and it was ALK negative by FISH. So in this case, I called this a cutaneous syncytial myoepithelioma, which is benign, and said that it had ALK1 expression immunohistochemically, but it was ALK1 negative for ALK1 fusion by FISH. So I think this is just aberrant protein expression, but due to some other underlying mechanism like overactivation, or maybe there's a mutation in there. I don't know what it is, but somehow ALK1 gene is being overexpressed as a protein, but it is not rearranged or fused with a partner gene, okay? So that argues against epithelioid fibrous histiocytoma here. So I thought this interesting. To my knowledge, this has not been reported in the literature. Again, I'm taking the risk that maybe one of you guys will go and run with this and go publish it. And if you do, maybe you can give a little shout out to me and say that you heard it from me first. You don't have to really do that. I'm just joking. Although if you do, I'll think you're extra cool. So eventually maybe I'll get around to publishing this case because I think it's kind of cool. And there are other times actually where ALK1 can be positive on immunohistochemistry, but negative for a gene fusion molecularly. And we'll talk about that actually later in another case in CPC session 2. So I don't want to give that away yet. All right. I hope you enjoyed that case. And just one flashback to the H&E to put it in your mind. This is cutaneous syncytial myoepithelioma with ALK expression by immunohistochemistry, but negative by FISH. And I think, again, the warty growth here, I personally attribute to just trauma-related changes from the topical wart treatment, but it's quite possible that this could be a weird induction phenomenon or something else. Unfortunately, we never had a biopsy before it was treated, so we don't really know if this is was originally there or is reactive. All right. Now, this case is great. I really love this case. It taught me a lot of good lessons, so I hope you like it also. Let me pull up the history here. This is case 4, a 19-year-old female with a distal forearm nodule, and I can't remember her age, but it was right around 19. She was late teens or early 20s, and it was a woman, and it was the distal forearm. And so this nodule was excised and sent to me as a consult. Now, if you've looked at this before, you probably noticed that we got a biphasic lesion here. We've got a solid nodule or multinodular area on the right-hand side here. And on the left, we have a multinodular, very loose myxoid lesion with patchy areas of cellularity. So let's start with the cellular area, because I think many times when I look at a slide and I see a lot of stuff going on, it's really easy to go straight to the cellular, most ugly looking area. And that's fine to do. But one thing I've noticed is because I have a bias towards doing that, sometimes I try to force myself to look away. I know that there's abnormality here in the middle, of course. So I try to look from low power at the rest of the slide first. Check the periphery, make sure there's nothing going on in the epidermis. I do this even in my regular Dermpath work when I'm looking at a basal cell or a nevus or a seborrheic keratosis. Before I go down closer, I look at 2x and just scan over to the edges real quick and make sure I'm not missing some subtle melanoma in situ in the background or something else. Check the margins real quick and see, am I dealing with something that's a completely removed, mostly removed, or broadly transected. Here in the United States, we get a lot of shave biopsies that are broadly transected. I know in other parts of the world, that's not as common. I'm not sure how it is in Australia. Maybe one of you guys can tweet at me online and tell me how it is. I'm always interested to learn the practice variations in different parts of the world because it really can be quite different. And some of the stuff that I spend a lot of time teaching about for my colleagues in the U.S. Ends up not being very helpful to other people in other parts of the world where they're used to getting complete excisions of things all the time. And I'm telling them, here's how you hedge on a shave biopsy. So in any case, that's one little tip for the junior trainees in the audience is don't just go straight high power on the most ugly area, okay? Look around first and get the lay of the land because you may pick up on subtleties that you would miss and that you would overlook or would ignore once you're fixated on what's going on in the bad area, okay? This area does look quite bad. It's cellular, large cells with kind of large nuclei, open chromatin, very, very pale, kind of washed out or vesicular open chromatin. Mitotic activity, that's one thing. I love digital slides, but I find that mitoses often don't stand out quite as well on scan slides. This is an older scan from an older model of scanners, so I think newer scanners may do better with this, but I know that some of my scan slides, I have trouble seeing the mitoses as well. But there were mitoses here, a fair number in fact. We do have a cellular tumor with large nuclei and scattered pleomorphic cells. I saw even on the glass H&E, I'm not sure if they show up here, but I saw several atypical mitotic figures that were distinctly abnormal. So pretty worrisome, right? High cellularity, large nuclei, pleomorphism, increased mitotic activity, and atypical mitotic figures. I mean, it's checking a lot of the boxes for malignant right away. So right off the bat, you'd be worried about sarcoma. But if it's a sarcoma, what kind? What are we going to call this? We could think about a melanoma, but that doesn't really look right for that. It's a nodule, deep down, I mean, if it were a melanoma, it'd be a metastatic melanoma. You could think of maybe a clear cell sarcoma, but the pattern's not really right. With the myxoid areas, you could think of a myxofibrosarcoma, which often do occur in the skin or subcutis, but almost always in old, usually elderly adults. I have never personally seen a myxofibrosarcoma in a patient in their teens or 20s. You know, some of that stuff has been reported in the literature, in the older literature particularly, but I'm often very skeptical of those kind of reports. Now, admittedly, I've not read them all, so maybe I'm being judgy without giving them a fair chance to prove themselves. But, you know, my personal view is if you think it's a myxofibrosarcoma, and the patient's under the age of 50 even, I would be very cautious. I think I've seen maybe 1 or 2 in people in their late 40s, but I'm still pretty skeptical there. So I really look at that very suspiciously and double check to make sure I'm not missing something else. If a patient's, you know, not in the 50s or older, and usually patients with myxofibrosarcoma, 60s, 70s, 80s, and beyond, okay? So atypical, kind of histiocyte-looking cells. The other thing I'll point out is a lot of multinucleated cells with similar looking nuclei to the tumor cells in the background. So I would argue that rather than being like background Teuton giant cells, these really probably represent tumor giant cells. And yeah, all the tumor cells look kind of histiocytic, but you know, these really have the same exact, to me, nuclear features as the background, this kind of washed out, almost vacuolated looking nuclei. All right. And again, scattered pleomorphism too, but many of the really ugliest looking cells are actually because of multinucleation. Now let's go over and look at the myxoid areas. I think in this case we got lucky because we had the myxoid areas. If you just had that hypercellular area, we could really struggle with this case, and we could potentially make a big mistake. In these areas, I think that anyone who's seen it before will recognize that we have thin, spindly cells that are kind of in elongated, almost chain-like structures that slightly swirl in this loose myxoid background. Now I know this background here really looks more like white edema rather than blue mucin or myxoid. I use the words mucin and myxoid kind of interchangeably. You know, I find path-trained people tend to say the word myxoid, and derm-trained people often use the word mucin when we're talking in the Dermpath world or the soft tissue world about glycosaminoglycans, ground substance, hyaluronic acid, whatever words you want to use for that stromal type mucin or myxoid change. Here we can see some blue mucin or myxoid change, but I do find that in slides, in recut slides, the mucin and myxoid stuff is the first of the stuff to fade, and it often goes and disappears really quickly in recut H&Es, which is one of the big benefits of scanning slides and digital microscopy for teaching, is it preserves that crisp original H&E, because there's nothing more disheartening than looking just a couple years down the road on recuts already fading, and it's pretty sad. But here's some kind of stippled dot like myxoid or mucin. So when we have these spindle cells with kind of chains that are swirling in a myxoid background in these little small nodules or nest-like or theque-like structures with fibrous septations in between, these are the features that remind us of what used to be called conventional neurothekeoma or myxoid neurothekeoma, and the more preferred modern term that I like now is nerve sheath myxoma. So the entity formerly known as myxoid neurothekeoma or conventional neurothekeoma is now referred to as nerve sheath myxoma. So when you see areas that look like conventional myxoid neurothekeoma / nerve sheath myxoma next to a more cellular lesion that often also has multinodularity with intervening fibrous septations, then what the answer is almost always is going to be cellular neurothekeoma. And the reason I've got a longer video that explains the history here, but the basic, very down and dirty explanation is that originally the first neurothekeoma was describing a lesion that looked more or less like this and was called neurothekeoma that had myxoid, kind of hypocellular swirled spindled nodules with fibrous septations in between. And then later, people saw that sometimes lesions like that had cellular areas. And so the idea became that lesions that were all cellular and multinodular were cellular neurothekiomas. Lesions that were all myxoid were myxoid neurothekiomas. And then lesions like this one that have both were mixed pattern or mixed type neurothekeoma. But with more modern immunohistochemistry, what we recognize is that's all rubbish, actually, okay? So the confusion of naming makes sense historically, but in modern times we know that if you have one that is purely like this and you stain it for SOX10 and S100, it will be positive, and those are true nerve sheath tumors, probably on a spectrum with schwannoma, actually. I've seen ones that actually had nuclear palisading resembling Verrucay bodies, and those are true nerve sheath tumors, and we should probably call those nerve sheath myxomas, okay? And if you have cellular areas, either partially or an entire tumor composed of cellular areas, we call those cellular neurothekeoma, and they are negative for S100 and negative for SOX10, and they are not at all a nerve sheath tumor, and the name is completely a misnomer, and we just have to accept, like many other entity names we use because they're entrenched in the literature, that we use the term even though it's a misnomer because people understand what it means. So just recognize that cellular neurothekeoma is called neurothekeoma, but is not a nerve sheath tumor. It often has myxoid areas. About 50% or more, I think, even of cases will have some myxoid area, so that's a very helpful clue to the diagnosis, and sometimes will strikingly resemble nerve sheath myxoma, but even these areas, they will be negative for S100 and SOX10. In every single case that I've seen that had a so-called mixed type, the entire tumor was negative for neural markers, S100, SOX10. So these are just cellular neurothekiomas with myxoid change, which is a common finding. Mitotic activity is common in cellular neurothekeoma, and in a small subset, you can even get atypical mitotic figures. Nuclear atypia is common and can be really extreme in a small subset of cases. Multinucleated giant cells, often with kind of an osteoclast-looking appearance, is very common in cellular neurothekeoma. Most cellular neurothekiomas that I've seen have a distinct kind of pale, washed out, histiocyte-looking nuclear chromatin. And so I feel like with practice, cellular neurothekeoma, just by the nuclear feature, I start thinking of cellular neurothekeoma. This nuclear pattern right here, I don't know how to put it into words. Pale, washed out, vesiculated, something about that with abundant cytoplasm and a kind of sheet-like growth with some multinodularity, right away I think of cellular neurothekeoma. And also I will think of epithelioid fibrous histiocytoma, which we saw earlier, because I feel like they have a similar cytologic feature, okay? Oftentimes the growth pattern is a little different, but I think those are fair things to think about. Okay, and what has been shown, fascinatingly, is that in the big studies by Chris Fletcher and Jason Hornick, I think still have the largest series in the literature, that even when you have atypical mitotic figures, really atypical, bizarre pleomorphic nuclei scattered in the tumor, hypercellularity, all of those patients still have a good outcome, and these tumors, even though they look malignant, they do not behave in a malignant fashion. So in cellular neurothekeoma, it appears that nuclear atypia and mitotic activity do not predict behavior, okay? The biggest struggle for me is how do we know for sure that we're dealing with the cellular neurothekeoma? Number one, all the cytologic and morphologic features I just told you, those are the most helpful things. The next thing is that immunohistochemistry, unfortunately, is not terribly helpful here. Yes, there are a variety of markers that have been reported as positive. NKI-C3, also known as CD63, is usually positive in these. Neuron-specific enolase, NSE, is usually positive in these. But those are both very non-specific markers. Neuron-specific enolase, to me, is total rubbish. I don't use it for anything. It stains all sorts of stuff, so I personally find it worthless, and I basically never order it. It's in the Vimentin corner for me, which basically means if someone sends me a consult and there's a Vimentin or an NSE, those are going to the bottom right side of the tray, where the negative controls go, and I flip them upside down. I don't even look at them. Rubbish, okay? They are worthless stains in my opinion, okay? Maybe I'm getting old and I'm being a little bit of a curmudgeon now, but I don't like those stains. And then also other things like PGP 9.5 and a variety of other markers, MITF, are reported in this tumor. But I feel the problem is those things are all pretty nonspecific, and most of them can stain melanocytic things and histiocytic things, which is going to be your main differential when you're looking at a case like this. Histiocytic things and melanocytic things could come into mind here. So if I think it looks like cellular neurothekeoma, and I do an S100 or SOX10 and it's negative, I feel pretty happy making the diagnosis just on ruling out a melanocytic tumor, because I think particularly when it's purely cellular without the myxoid areas, I've seen some cases that can have some tight nesting that really look like a Spitz nevus or a spitzoid or other melanocytic tumor, and because they can have mitotic activity and atypical mites, things that are totally fine in a cellular neurothekeoma, but much more maybe concerning in the context of a melanocytic lesion. So I think it's really important to make sure that you've excluded a melanocytic lesion. Now, in this particular case, I don't think you wouldn't seriously consider a melanocytic lesion. Okay, so I've talked to death on that one, and now I'm going overtime, but I think it's really important. The other thing that I want to point out is the real awesome kicker of this case that would be so easy to overlook. Look at this. This is classic tight little theques or nests of bland histiocytoid cells, the classic cellular neurothekeoma, just a little bit of it, a little tiny cluster of it right at the edge, which seals the deal here if we had any doubt. This is definitely a cellular neurothekeoma. And there's another area up here in the corner that is a little bit more robust, but also if you've seen a cellular neurothekeoma before, I think you'll agree with me. Even if the stuff in the middle here looks really wild, this stuff looks great for cellular neurothekeoma. And this is now, I have also seen another case years later after this one, and it was one that had actually been reviewed by another pathologist and called a sarcoma in a young adult woman. And I reviewed it again, and I think that pathologist, a very good pathologist actually, I think they just overlooked an area like this that was there. And after looking at that, I think this is just a atypical cellular neurothekeoma, and my personal view is I do like these to be excised with a negative margin, ideally if it's clinically feasible. Now, when it's on the nose of a kid or a young adult, you gotta then have to weigh the pros and cons there. But I do feel like if it were on me and I had atypical mites and stuff, even though the literature says it's fine, I personally would want it removed. If it were on my kid or my wife, I would want it removed. But I'm also a paranoid pathologist, so maybe that's overkill. So I think it's worth having a discussion of risk versus benefit. I think the literature supports that maybe it's okay to watch and wait on these. But I think if it's not too morbid to remove it with a little margin, probably that's a good idea. I can't remember in this case if I told them to go back or if I said because it's pretty much out here just focally at the margin. I think I may have told them to watch and wait closely. And I never did receive follow-up, but I never got anyone contacting me and telling me, oh, by the way, something bad happened here. So it's always unsatisfying because you don't really know what happened in a case like that. But in any case, I hope you enjoyed this case, even though I spent a long time on it. I really feel like there's a lot of real great take-home pearls to be learned. And it's a case that years and years later I've remembered distinctly because I learned so much from it. All right. This is another one I learned a lot from. All right. I'm going to try not to go too long. This is one that we reported in the literature just not too long ago, actually. And man, this is one I almost missed. Case 5, 80-year-old female with a 3.5 centimeter painful erythematous skin nodule above the knee. That's actually how it was reported by the treating physician. A punch biopsy was done. And this is important to know. This case was sent to me in consult, partially worked up already. The outside pathologist did some stains, sent it in, said what they were thinking. So I got it with the history clinically, what it looked like on H&E, and some immunostains. It's really important, I think, to look at H&Es cold starting out. And then always I want the clinical history. I want to know everything about the case, but I like to personally look at it because it gives me the most open mind and it reduces my bias and gives me a free mind to think on free association, just on the morphology, without knowing the age or the site or anything else. What could this possibly be? So here is a time where I guess I didn't do that. I don't remember exactly, but I think I was busy. I was looking at it. I thought, okay, we got an older lady with the round blue cell lesion in the dermis here. It's kind of falling apart, and it's a biopsy where the epidermis is falling off. We've got barely any epidermis there to look at. So, I can't tell if that's because of confluent melanocytes. Maybe it's just a small cell melanoma, but SOX10's negative. I have some blue cells that are maybe molding together here. Down here, you can see them better, a little bit of clear cell change maybe. So, the main thing I think of here in an older person with the sheets of round blue cells and a little bit of molding, and there was some scattered mitoses, if I recall. Yeah, I think here's one right here. This is going to be a Merkel cell carcinoma, maybe a lymphoma. versus maybe a small cell pattern melanoma, although I rarely see melanomas that are purely small cell. I mean, I know it happens, and I know you guys have seen a lot of melanomas. Most of you in your practice probably have seen more than me, and I've seen quite a few now. But in any case, I feel like usually when I've seen small cell pattern melanoma, it's mixed with other stuff. So in this case, I'll tell you what the stains were that we got up front, okay? Focal dot-like expression of low molecular weight keratin, and I did some additional keratins, and there was also focal dot-like CK7 and pan-keratin. Let me show you some of these stains here. This is CD56, also a marker that I honestly, very sensitive for neuroendocrine differentiation, but it is very nonspecific. I use it kind of in the setting of looking for NKT cell type of lymphomas and leukemias, for looking for, like gamma delta T cell lymphoma in the subcutis. In certain select settings in hematopathology, I will use it. I really personally don't like it that much as a marker for neuroendocrine differentiation, just because it's so nonspecific, okay? But it is positive here, and it came in with this done outside. So that's positive. But this is chromogranin, which I also don't love because it's not as good. I like synaptophysin and INSM1 insulinoma, like protein 1. That's my favorite neuroendocrine marker. But here we do have evidence of neuroendocrine differentiation. There's focal kind of dot-like and cytoplasmic granular chromogranin. There's CD56 for whatever that's worth. We've got, here's a pan-keratin, and there's dot-like expression, like you would see in a Merkel cell. And so in Merkel cells, of course, CK20 has dot-like expression, but I often find that pan-keratin, CAM5.2, sometimes the neuroendocrine markers, neurofilament, a lot of those will also have dot-like paranuclear expression, or so-called Golgi expression. So right off the bat, I'm leaning towards this being a Merkel cell carcinoma versus maybe a metastatic small cell lung cancer, which is rare, but occasionally will show up as a presenting sign of small cell lung cancer in the skin. And then, I got ahead of myself. I won't tell you what that is yet. So other stains have been done, like some heme path markers. We added to the panel. We did a MUM1 for myeloma. It was negative. CD43 and CD45, which I like that combination as kind of a pan white cell marker, because occasionally I've seen some hematopoietic malignancies, particularly myeloma, that's CD45 negative, and people have almost misdiagnosed it, and CD43 will pick those up. So I like to use 43 and 45 in combo. If those are both negative, pretty good chance of ruling out a malignant or ruling out a hematopoietic neoplasm for the most part, in my experience, okay? TTF1 was negative. And unfortunately, as much as I wanted this to be a Merkel cell carcinoma, it was negative for synaptophysin and negative for CK20. I didn't have INSM1 in my lab at that time. So keratin 20 negative, but everything else, all the heme things have been excluded to the best of our ability. We excluded a metastatic small cell carcinoma. We didn't know of any other history this patient had. So putting everything together, I thought, there is some keratin that's dot-like. There is some neuroendocrine expression. The cells are round blue cells with mitoses and the dermis of an older person on the extremity. And I didn't have Merkel cell polyomavirus in my lab, and in my experience, I found that to be a bit hit or miss for Merkel cell. As is well known that not all cases of Merkel cell have Merkel cell polyomavirus, and so it can be helpful, but it's not a routine case I honestly use in working on Merkel cell personally. So I looked at it, showed to colleagues, did a couple rounds of stains, and I decided, I'm going to just call this thing CK20 negative Merkel cell. I think it makes the most sense. It's rare, but it's well reported in the literature that this can happen. And then I looked over all my stains again before I signed it out. And oh, by the way, S100 was negative, or had like a little bit of blush, but mostly negative here. And I looked at everything again, and I thought, what else could this be? Did I do everything? And I find that helpful, especially in a complicated case where you either got it as a consult with stains done up front, or you had to do multiple rounds of stains, or your initial diagnostic impression, what you thought it was going to be, was changed because one of the results of the stains, and then you kind of went down a different branch of the diagnostic tree, so to speak. Those are all situations where I feel like we have a potential for making a mistake. Because when we look at something cold and we start down the diagnostic pathway, if there's any of those things I just described, sometimes make us skip forward one or two or more steps in the diagnostic algorithmic tree of workup. And sometimes we can miss crucial cutoffs where we would have gone down a different branch, but we didn't think of it because we skipped ahead of that branch in the tree, if that makes sense. And maybe I need to somehow make a diagram for this. But in any case, as I looked over the case, I thought, You know, one thing I usually do, if I've got a tumor that I don't know what it is, in soft tissue pathology at least, an ugly, poorly differentiated tumor, a malignant spindle cell tumor, and I don't know what it is, I often start with a basic panel of stains. Pan-keratin, S100 or SOX10 for melanocytic or neural tumors, Desmin for rhabdomyosarcoma and leiomyosarcoma, and actin, although in the skin I don't use that as much. It's not as useful because it's pretty non-specific, but it's how I was trained. So, and depending on the situation, I might do a vascular marker too. Some of you might have looked at the spaces here and thought of a vascular lesion. I think we actually did ERG in this case and it was negative, okay? But I think it would be totally reasonable to think of the angiosarcoma here too. I think these little spaces are actually pseudovascular at first glance, or maybe something else, which I'll show you in a minute. But I realized, you know, I did a big panel, I never did Desmin. And here's Desmin. Like, as Tim McCalmont likes to say about immunostains, this is level 11. Like, turn the amp, you know, if you're an electric guitar player, turn the amp up to 11. Screaming, blazing distortion, metal music level, Desmin expression. And I thought, oh my gosh, I about made a huge mistake. This is a rhabdomyosarcoma. Look, you can see some dot-like Desmin expression, which sometimes happens in rhabdos. And actually, when we published this, one of the reviewers suggested that that's actually really helpful for alveolar type rhabdomyosarcoma, which is what this ended up being. I am not aware of that in the literature. I could not find a reference, and I wished I could have got that reviewer to give me a reference. So if any of you know a reference, maybe I missed it on my literature review, but a dot-like Desmin expression, perinuclear dot Desmin expression as being a useful marker for alveolar rhabdomyosarcoma. I'm a soft tissue pathologist, and I, to my knowledge, had never heard that before and couldn't find it referenced in any of the books or papers I looked at. So the next step is Desmin positive in a malignant tumor. You do myogenin and myo-D1. In this case, my lab's myo-D1 at that time didn't work very well. So I just did myogenin, or also known as MYF4, and it's blazing positive in like 99% of the nuclei. Alveolar rhabdomyosarcoma usually is like strong, wall-to-wall, 4+, turn the amplifier up to the 11 level, myogenin expression. So to me, when I see alveolar rhabdo, I always basically by definition confirm this with molecular, because usually at least these tumors almost always arise in children or maybe teens or young adults, extremely rare in elderly individuals, and extremely rare in the skin, even in kids. Rhabdomyosarcoma is very rare in the skin. I co-authored a paper with Steve Billings and Victor Prieto and Trent Marburger about 10 years ago, where we found 11 cases of rhabdo that seemed to be primary in the skin and subcutis, and that was scraping the consult files of multiple large centers. It's really rare to see rhabdo in the skin, even more so in an elderly adult, even more so when it's alveolar rhabdo, which really is most commonly in kids and young adults, okay? So this was like a triple rare, triple whammy, all of the possibilities. This was the last thing I expected, and I almost missed it. I was sitting at my desk after having done all the workup, ready at the microscope to verify my report, and I thought, I didn't do a Desmin. So man, I learned an important lesson here to go back, and I just do that now on a complicated case where I've done multiple rounds of stains. I just look over everything again and think, is there anything I'm missing? Is there anything I would have done if I got a round blue cell malignant neoplasm cold in a kid, in a deep soft tissue site, in a whatever other thing? And of course I would have. My normal round blue cell panel in a kid or deep soft tissue, Desmin's one of the first line things I do. And I didn't do it here because I jumped straight away to, this is probably Merkel cell carcinoma, maybe could be lymphoma or something else. And I did stains along those lines, and I skipped 2 or 3 steps down the diagnostic tree. So, long work up there. You can find this, we published, I think it came out this year in 2022, actually, I think it finally came out. And we did a PAX, this was positive for fusion of FOXO1, PAX3, and unfortunately, some sarcomas, when they arise in the skin or subcutis, are much more indolent than their deep counterparts. Unfortunately, that's not true for rhabdos. They usually still have very aggressive behavior, and alveolar is a particularly nasty tumor. This patient had a positive inguinal node that was discovered at the time of diagnosis here, and later went on to develop retinoperitoneal adenopathy, hilar adenopathy, and the patient died of disease, I think, was sent to hospice and died about 18 months after diagnosis. So rapidly aggressive progression of this disease. I'm not sure if this would have made a difference misdiagnosing this as Merkel. I think the treatment would have been different because Merkel cells often get treated with, checkpoint inhibitors and often respond dramatically. And to my knowledge, I'm not aware if checkpoint inhibitors have been tried on rhabdos yet. They've been tried on lots of other tumors. But it seems like, to my understanding, many sarcomas that checkpoint inhibitors have been tested on don't seem to have dramatic results yet, to my knowledge, unfortunately. But I'm not aware of all the literature on that. So in any case, a really unfortunate outcome, but I think there's a lot of really important lessons to be learned here. And look back at the H&E again. I know I'm way over time, and I hope that you guys will all forgive me, or maybe they'll force me to cut this case and you'll never end up seeing it. I don't know. Look, it's making alveolar structures. I just had never seen alveolar rhabdo in the skin. I think, to my knowledge, if it's been 10 years, but if memory serves correctly, I don't think that we had any alveolar rhabdos in the skin in our cutaneous rhabdo study that we published in 2012. Maybe I'm wrong about that, but it's been a while since I've looked at that paper. But what I initially interpreted as just disc cohesion due to processing artifact or something else is actually alveolar space formation, which is due to nests, basically, or nodules of tumor cells that become discohesive and fall apart, and the outer layer is retained along the fibrovascular septa, and that's why alveolar rhabdomyosarcoma makes the alveolar spaces. And in other soft tissue tumors, like alveolar soft part sarcoma, which is, I don't think I've ever seen a case in the skin, the same kind of thing happens. It looks quite different than this. Those tumors look alike in name only. They don't look anything alike microscopically. So I've got video on that on YouTube. You can check out on my YouTube channel if you want. Okay, alveolar rhabdo of the skin. Wow, what a case, huh? Okay, maybe I should have put some boring cases in, but I went for the home run, the grand slam, and gave you guys the best of the best stuff. This is another round blue cell tumor. This one was a 17-year-old female with a soft red-blue nodule on the anterior thigh, present for at least 4 years, and we know that this is all, the history is exactly as it was reported because we reported this case in the literature also. So this one also is amazing because it had been present in the patient's chart documented for 4 years. So another doctor had seen it. They thought it was a vascular malformation. It still was there growing about 4 years later, so they did an MRI and said there was some vascularity to it, and they thought maybe it's a weird hemangioma, but it had some potential necrotic spaces on imaging, they thought. It was necrosis, so they thought that was a little weird, but they favored hemangioma. Okay, so it was finally excised after that, and we got this amazing, beautiful excision done by a pediatric surgeon. It was done at a children's by a pediatric surgeon because the patient was a teenager. And what we have here is a round blue cell tumor, sheets of uniform, monotonous round blue cells arranged in diffuse sheets with scattered mitoses. There's a mitosis right here. It's a little hard because it's a dark scan, but there were multiple mitoses. There was no pleomorphism. Lots of empty spaces that I think are discohesion and falling apart of the tumor. Also some blood-filled spaces. There were some vessels around it. Oh, I forgot to mention they did an ultrasound and saw vessels around the periphery, which I think is what these are. Vessels that I think are just background true vessels. We also have some areas that you could think are either pseudovascular or vascular spaces where the tumor's fallen apart and there's blood inside. I favored those to be kind of artifact or pseudovascular space. But, here you can see that, blood-filled spaces. Sorry, it's taking a second to load because I've got like 30, tabs open here. There's some blood-filled spaces. I think if I recall, I did vascular markers and they were negative here, but I was pretty sure it was not a vascular tumor. And there are some foci, small foci, of tumor necrosis. Look, that the cells are dying and becoming little ghost outlines of themselves, so little pockets of necrosis. So even though it's not pleomorphic, I thought this is a malignant round blue cell tumor. It's very uniform, and that's generally in soft tissue pathology, that's a clue that you're probably dealing with a translocation or gene fusion associated tumor. Most gene fusion or translocation sarcomas or non-sarcomas, in soft tissue pathology at least, have uniform monotonous nuclei, not pleomorphism. Pleomorphism usually goes with random gains and losses or aneuploidy, okay? So there's some exceptions to that rule, but it's a pretty helpful tip in soft tissue pathology. So here I thought, well, could it be Ewing's? Round blue cell malignancy, I always think of Ewing's. Could it be rhabdo? And I had one other idea because there were some kind of pseudovascular blood-filled spaces in the middle. I thought about another tumor, angiomatoid fibrous histiocytoma. Despite the name, unrelated to dermatofibroma or benign fibrous histiocytoma, it's actually an intermediate malignant potential tumor that occurs in kids or adolescents and has sheets of round blue cells that are kind of histiocytoma or histiocytoid and has blood-filled cystic spaces in the middle and has a cup of lymphocytes and plasma cells around the outside, but sometimes it lacks some of those features. So I thought maybe it could be that there's not really a lymphoid cuff, but maybe it's one of those that just lacks the cuff. So what I did is I did CD99, which is level 11, blazing positive. This is the kind of positivity we want in a Ewing sarcoma. Strong, diffuse, 4+ if you like, or 3+, whatever. A blazing positive, membranous staining, okay? So CD99 is very nonspecific, but it is very, very sensitive for Ewing sarcoma. So if I do CD99 on a round blue cell tumor and it's strong, diffuse, positive like this, then that is a good point towards it being Ewing sarcoma, and then I proceed to molecular testing. I personally like to always confirm my Ewing sarcomas with molecular. Okay, but there are other things that can be CD99 positive. If it's negative or patchy positive, then it's probably not Ewing sarcoma. Like 95% of Ewing sarcomas have strong diffuse CD99 expression. But there are other things like CIC-DUX4 fusion sarcoma and B-core fusion sarcomas and a growing number of other so-called Ewing-like round blue cell malignancies. Most of these are deep soft tissue tumors or bone tumors. Rarely do these things show up in the skin, but it's important to keep them in mind because when they do, it's important to sort that out because some of them, like Ewing's, when they're in the skin, is actually very indolent. And other ones like CIC-DUX4, when they're in the skin, they're very aggressive, just like they are in deep soft tissue. So distinguishing this from other things in the round blue cell category is important. It usually requires immunohistochemistry, usually with the addition of molecular testing. Okay? Here is another stain, EMA. I did this because angiomatoid fibrous histiocytoma is about half of cases have co-expression of EMA and desmin. In this case, EMA was positive, desmin was negative, okay? So what am I to do? I was still stuck between, and CD99 can be positive in both. I thought it's either Ewing's or it's angiomatoid fibrous histiocytoma. Morphologically, I kind of vote for Ewing's here, but it had the blood-filled spaces. It had been present for 4 years. That'd be weird. Ewing's is usually rapidly growing tumor. And the skin is a pretty rare site for Ewing's. It happens, primary cutaneous or subcutaneous Ewing's, but it's certainly unusual. So what I did is molecular. I started with FISH for EWSR1. The problem is that that's going to be rearranged in most cases of angiomatoid fibrous histiocytoma and also in essentially all cases of Ewing sarcoma. So it was rearranged here. So the next step, so this is why it's important to know what the fusion partners are of the different things in your differential. And then you can think through, should you do FISH, RT-PCR, next-gen sequencing? What's your approach molecularly in testing? So in soft tissue pathology, I think it's important to know your differential, and that's where morphology and the clinical situation and the immunostains help guide you. And then you can pick your molecular testing from there. And this is another one where I had a nice discussion with Dr. Bridge ahead of time and said, Julie, I'm between these entities. So I'm kind of torn, what's the best approach for molecular testing? And at that point, we decided to use FISH up front. Then we confirmed the fusion partners, and this was positive for EWS fused with FLY1, which is the most common fusion seen in Ewing sarcoma, and there are some variants. And also we tested EWSR1 CREB1 and EWSR1 ATF1, which are the two of the fusions that are seen in angiomatoid FH, and those were negative. So this is an interesting example, and the best example I've ever seen of primary cutaneous or primary superficial, I guess it's in the subcutis also, Ewing sarcoma. And I actually got to meet this patient face-to-face in real life and show her slide. She and her mom wanted to meet with me and discuss her pathology, and I did that as part of a patient interacting with pathologist quality control thing that I was involved in. It was a really wonderful experience. And I've worked a lot with patient groups, rare cancer patient groups on Facebook. I've got a TED talk about that. You can search just for my name and TEDx if you want to see that. It's on the TEDx YouTube channel. It's really been life-changing for me. I've loved working with rare disease patients. And this girl, to my knowledge, is still alive and well and doing fine with no recurrence or metastasis. Usually these are much more indolent in the skin or subcutaneous. Some people debate whether chemotherapy is even needed for these, but there have been rare cases that behaved aggressively. So in this case, the pediatric oncologist discussed with the family, and they decided to do kind of a shorter course of chemo. The patient did great with it, and so far alive and well and happy. And so I'm really glad there was a great outcome here, and we were able to solve the case. EMA positivity, not specific. Also, remember that Ewing sarcoma, again, rare in the skin, but when you see a monotonous uniform round blue cell tumor, keep Ewing in mind. I have seen it once in an elderly patient in the skin as well. So rare things that should not be in the skin and should not be in kids sometimes can happen in old people and sometimes can happen in the skin. So just always keep that on your radar for rare weirdo things, okay? Then finally, the other thing is that keratin can be positive in like 25% of cases, and so can neuroendocrine markers. So this is yet another thing that if you had this in an old adult, you could easily get some keratin and some synaptophysin, and you could mistake this for Merkel cell carcinoma, okay? Important to keep these round blue cell tumors in mind, even though they're rare. All right, I think that finally is case 6. I'm only like 20 minutes over time. I hope you enjoyed, and I'll be back with CPC session 2. Thanks for watching. Hi, it's Jared Gardner. I'm back with CPC session number 2. I'm going to try to go faster this time so that we get done in time. We'll see what happens. All right, this is case 7. A 9-year-old female with a nodule in the back. Clinically, they thought it was a lipoma versus a cyst. If you've followed me online, you know I love to rant about that. Everything is a lipoma or a cyst clinically until it gets biopsied and it turns out to not be a lipoma or a cyst. So just a reminder that anything that's a deep nodule, doesn't matter what it's made of, it can look just like a nondescript skin-colored bump clinically that would resemble a lipoma or cyst. So they did ultrasound on this, though, because of the size of it, I think. And it showed a well-defined complex mass with internal echogenicity and a vascular component. And on the differential on ultrasound was hemorrhage or hematoma versus abscess, but neoplasm can't be excluded. So they went and did a surgical excision, and unfortunately, the lesion fragmented during surgical removal and drained fluid, serous fluid contents and fat. So now what we have is this fragmented material here, submitted for pathology. And I apologize for the little cut chatter lines here on the tissue, but this is the best section I had available. So I hope you had a chance to take a look at this. It's fragmented, but also it's very heterogeneous. We have, I think most notable, these cellular areas here that have fascicles that almost vaguely start to make kind of a herringbone pattern. And if we zoom in closer, you can see it's a range of kind of spindle to epithelioid cells with some pretty significant hyperchromatic pleomorphic atypia in the nuclei. There are multiple areas with hemorrhage and extravasated erythrocytes that appears to be potentially more than just a procedural change, but actually maybe some blood in the tumor or the lesional cells themselves. And if you look around, though, you can see that there are areas also with kind of sclerotic, almost keloidal-like collagen and spindle to boomerang-shaped cells wrapping around the collagen. And I'm not just saying boomerang cells because of an Australian audience. I promise I say that in my practice when I'm teaching all the time, and maybe it's inappropriate, the description, but these kind of, you know, angulated or triangle cells that wrap around the background collagen. So that's kind of interesting. And other areas, let's look here. We can even see some bluish kind of mucin or myxoid background changes and loose kind of wispy arrangement of the cells. So quite a wide range of features here. Here's another slide that has more myxoid area. And even you could think of almost a neural kind of appearance in some foci. So it's very heterogeneous. And here's a couple little round world nodules. And then there's this. We have big cystic spaces that seem to be more than just fragmentation from the surgery, but actually maybe a cystic or pseudocystic component that was maybe present in the lesion inside the patient. And there's blood and some fibrin in the center here. And that goes along, I think, with that idea of kind of a complexity that was described on the ultrasound. And also, we see pretty prominent inflammatory component around the outside. This is a little bit dark stain and scan, but I'll tell you, these are all lymphocytes and some plasma cells as well. So we have pretty brisk inflammation around the periphery embedded in this dense fibrous or sclerotic kind of pseudo-capsule around the lesion. And on this slide, you can see more of the same. Dense inflammatory infiltrate around the outside, lymphoplasmacytic infiltrate, fibrous tissue and sclerosis, hemorrhage, pseudocystic spaces, and then this wide variety of morphology, spindled cell proliferation with areas showing some prominent atypia. And there were even, I think, in some of the inflammatory component, even some vague germinal center formation. So I wonder, did you put together a differential or did you come up with the answer for what this is? Because it's kind of a rare bird and it's a tumor that's good to know about because it has a wide range of morphologic features. And so things like that can really confuse us sometimes when it's rare and has a wide morphologic variation. So I'll tell you, this is an entity called angiomatoid fibrous histiocytoma. And this tumor, despite the name, actually has nothing to do with dermatofibroma, aka benign fibrous histiocytoma. So it's frustrating, and in fact, when I sign these out in my report, I add a comment that says, this is a rare tumor of intermediate malignant potential that usually arises in kids or sometimes young adults. I've rarely seen it in older adults also. And despite the name, it has nothing to do, it's totally unrelated to benign fibrous histiocytoma, open parentheses, dermatofibroma. And the reason I say that is back during my fellowship training with Sharon Weiss, I remember we saw a case of this, and the person who sent it in consultation called and was asking me about it. And it took me a few minutes to realize that their confusion was they were asking, why do we need to do all this excision and stuff? Because they thought it was just a variation of dermatofibroma. So you could get this confused with aneurysmal fibrous histiocytoma, which is actually the name for dermatofibroma with aneurysmal change, hemorrhage inside a big dermatofibroma. Totally unrelated to this entity here, angiomatoid fibrous histiocytoma. So that's why I always call things dermatofibroma, aneurysmal type, or fibrous histiocytoma / dermatofibroma, aneurysmal type, which is the dermatofibroma with blood-filled spaces. I make sure I word it that way so that no one ever confuses it with this rare tumor here, angiomatoid fibrous histiocytoma. And because this is rare enough, I always add that commentary on the end that explains what this is and what needs to be done. So the classic example, let me show you a classic example real quick. So you can use that as your gold standard. And then you can kind of conceptually think about this weird one that we're looking at here. So to me, this is like the most classic gold standard example I've ever seen. And this is a subcutaneous nodule on the forearm of like an 8-year-old girl, I think. And what we see are 3 components. So the triad, the classic triad for this tumor, is a nodule that has sheets of histiocytoid cells with kind of a syncytial arrangement, and then a central cystic area that usually has serum or blood and fibrin in the middle with variable amounts of hemosiderin. And then out at the periphery, there is a fibrous pseudocapsule with a thick band of lymphocytes and plasma cells. So that's the classic triad. Blood-filled cystic space surrounded by sheets of syncytial histiocytoid cells surrounded by a band of lymphocytes and plasma cells with a fibrous pseudocapsule, often occurring in the subcutis on the upper extremity of a child. That's like the perfect textbook example if you were going to write a test question. So this one, I'll post all the slides from the meeting, including this one here, on my kikoxp.com account so that you can come back and review them later. And I'll send the links to all this and some other goodies to the meeting organizer for them to share with all of you. So burn this one in your brain, but remember that they don't all look like this. In fact, there's a wide range of features, and my friend Summer Bowman, along with Steve Billings, they wrote a paper about the wide range of morphologic features you can see in angiomatoid fibrous histiocytoma. I've seen ones that looked whorled and like perineurioma. I've seen ones that were prominent herringbone fascicles that looked like a synovial sarcoma, and everything in between. Also, these tumors have a translocation, several different translocations in fact. And I told you in CPC Part 1 that translocation-associated tumors don't usually have pleomorphism. Well, guess what? Angiomatoid fibrous histiocytoma breaks that rule, and many others, because here's scattered pleomorphism. So this is a notable exception to the rule about not having pleomorphism in translocation-associated or fusion-associated spindle cell tumors, okay? So there are 3 different fusions that have been described in this tumor, and the most common is EWSR1, the Ewing's gene, fused with CREB1. That's 90% of cases, is EWSR1 CREB1. And then you can also have EWSR1 ATF1, which is shocking to me because that's the same translocation you see in clear cell sarcoma of soft tissue, which doesn't look, stain, or act anything like angiomatoid fibrous histiocytoma, and yet it has the same molecular abnormality sometimes. Mind-blowing to me. And then also FUS ATF1 is an alternative. EWSR1 and FUS are very similar genes, so they can kind of trade places in fusions sometimes. Okay, what about immunohistochemistry? In this case, and I'm going to go back and forth between my library here, because I tried to load up all the slides and my computer was not having it. Okay, you know what? I actually won't load them because they had trouble loading before, but I'll just tell you, and they weren't real impressive. But this case had patchy expression of desmin and EMA, and about 50% of cases of angiomatoid fibrous histiocytoma will have desmin and or EMA expression. So you don't always have them, and you don't always have both of them together, but if you see either of those in the setting of any of the things we just talked about, consider the possibility of angiomatoid fibrous histiocytoma. This case also had ALK expression, which a few years ago people described, some authors described as being a really common finding in angiomatoid fibrous histiocytoma to see ALK immunohistochemical expression, but molecularly these tumors do not have fusion of the ALK gene, so kind of similar to that unusual case I showed you of cutaneous syncytial myepithelioma in CPC Part 1, where the ALK fusion was negative by FISH, but there was still ALK staining. So I actually find ALK a really helpful diagnostic tool by immunohistochemistry for angiomatoid fibrous histiocytoma. So these tumors, what are they? They're, like I said, they're intermediate malignant potential. In the old days, people thought they were a variant of malignant fibrous histiocytoma, which is the old school name, the obsolete old school name for undifferentiated pleomorphic sarcoma. But then later people recognized that this is not actually related to a sarcoma. This tumor usually has indolent behavior. It can recur locally. It sometimes metastasizes to regional lymph nodes, but distant metastases or death from disease is very rare. So aggressive behavior is rare. Ideally, it's good to excise these with negative margins and to follow the patient. But the good thing to know is that most patients with this do very well. Okay, but they can sometimes develop regional lymph node metastases. All right, so a really great example of the wide variation you can see in angiomatoid fibrous histiocytoma. And I've seen a couple cases like this that were fragmented and blood-filled, and where the tumor cells where most of the stuff we were looking at looked like fibrosis, sclerosis, inflammation, and blood, non-specific reactive changes, but only focally you could see a spindle cell tumor component. So be on the lookout when you see blood and cystic change and brisk inflammation, especially in a child or young adult. Go looking and see if there's any atypia or areas that look like neoplastic spindle cells, not reactive, and then do some stains, EMA, desmin, ALK, or you can just go straight to FISH for EWSR1 and see if it's that. Because I saw one before where I was almost tricked into calling it reactive, and it turned out it was in a young adult, actually, if I recall, on the foot. And I thought it was all just hemorrhage and maybe like a ruptured ganglion cyst with inflammation. And one of my more astute colleagues said, I think it could be angiomatoid FH, and we did the FISH and it was positive. And I was ashamed, but it was a good lesson because now when I teach about this, I can share that shame with all of you so that you can see that it's easy to make this mistake in cases where the spindle cells aren't prominent. But here we had a big sheet of it in a different block. All right. Well, I said I was going fast, and here I've spent 13 minutes on case number 7. Every time this seems to happen. Okay. Let's see, case number 8. And I'll load up the stains here while we're thinking. So this was a 33-year-old male with a violaceous nodule in the ear canal. It had been excised several years ago, but recently it recurred. So this is a re-excision. You can see this little streaks here. I call this the Wolverine sign, like Wolverine took his adamantium claws and sliced right through the tissue. I hope I don't have any trademark violation for the X-Men trademarks, but in any case, hopefully I won't get in any trouble. But I think that this is usually a good sign that there's something hard in the tissue. Bone, calcium, foreign material, or maybe it was the case before and the histotech just hadn't changed the blade yet. But anytime I see this, I go looking for something hard that would have gotten drug across the tissue and scratched it open. In this case, they were down, the ENT surgeons were taking this pretty near the mastoid bone, if I recall. So in any case here, we have this nodule that's cellular, and then we have some background stuff that's just some increased vessels and inflammation, and I'll go show you that in a minute. But first, this nodule here is a kind of cellular lobular proliferation of vessels with very plump endothelial cells. And it's in some areas hard to tell that you're looking at vessels because they look almost like little nests or little islands, and you can't even see a lumen. It also looks very busy. There's kind of looks like blood-filled slit-like spaces, plump endothelial cells. Occasionally you'll find some mitoses. Could look kind of scary. You could think of Kaposi sarcoma. You could wonder about maybe a subtle angiosarcoma or something else. Also, some of the cells have vacuoles with little erythrocytes in them, kind of like the blister cells of epithelioid hemangioendothelioma. So you could have your brain going to a lot of different places, some of which are kind of scary, and wondering, is this a bad vascular tumor? But no, it's not. One clue is that in the background we have mixed lymphocytic infiltrate with scattered eosinophils. There's some hemosiderin and some blood, but look at all the eosinophils there. So I think you probably see where this is going. And here, where you can see a more well-formed vascular channel, you can see epithelioid endothelial cells bulging into the lumen. All right? So this is angiolymphoid hyperplasia with eosinophilia, also known as epithelioid hemangioma. Now, in the WHO, the 2020 4th edition of the Bone and Soft Tissue WHO book, they recommend that we not call this angiolymphoid hyperplasia with eosinophilia, and that we instead call it epithelioid hemangioma. And I think their point's well taken. These are truly neoplasms, at least the true ones are. There may be some reactive things that mimic this, that is particularly in the skin. But in any case, these probably are really neoplastic. About 50% of cases, if I recall, have fusions involving the FOS, FOS, or FOSB genes in around half of cases. So that goes with the idea that these really are neoplasms that just bring along a brisk inflammatory infiltrate, often with lots of eosinophils. Let me show you away from this kind of cellular nodule. Well, actually, here's another cut of the cellular nodule. You can see the vascular channels, but the ones that are kind of compressed and have really plump endothelial cells, those sometimes give people concern because they can look kind of scary. But here in the background, look what we have. Brisk inflammation, and if we go inside these very brisk inflammatory nodules with lymphocytes and eosinophils, we'll start to find vessels with epithelioid cells lining the lumens. So this is kind of a more subtle background component of angiolymphoid hyperplasia, aka epithelioid hemangioma. So usually I follow the rules of the Bone and Soft Tissue WHO book, but I'm going to tell you, as a soft tissue and bone pathologist who's also a dermpath, this is one place I make an exception. When I sign out this tumor, I still call this angiolymphoid hyperplasia with eosinophilia, open parentheses, epithelioid hemangioma, close parentheses, or vice versa. I will say one point of potential confusion is, and it actually happened in the past, of an epithelioid hemangioma, someone could read that and go search for it on Google, and one of the things that will come up is epithelioid hemangioendothelioma. And in fact, I had a time where a resident had contacted me about a case and asked about this, and if they needed to do a CT scan of the lungs to make sure there weren't lung metastases. And I said, oh, no. You're thinking of epithelioid hemangioendothelioma, not epithelioid hemangioma. And they said, oh, you know what? I looked for it, and actually one of the links or the articles or resources that popped up was actually about epithelioid hemangioendothelioma. So I think it's important to know that those names do sound alike, and even though obviously they are different words, to someone who is not really familiar with these entities, it could get confused. And so that's a good point to know. These vessels, I really like this case because you can see that even the scattered vessels really have very epithelioid endothelial cells. And I think that anytime you have a vascular lesion with epithelioid endothelial cells, you have the potential to get these cytoplasmic vacuoles in the endothelial cells. You can see this in epithelioid hemangioma / ALHE. You can see it in epithelioid hemangioendothelioma, and sometimes even in epithelioid angiosarcoma and others. So just recognize that vacuoles don't necessarily mean epithelioid hemangioendothelioma. They're often seen in other tumors, particularly in ALHE. I see them. Okay, here's another vessel. Okay, and then the other thing I wanted to point out about this case. And by the way, this patient, their previous biopsy and excision or whatever it was a few years ago was also called angiolymphoid hyperplasia / epithelioid hemangioma. So it was known what this was already. And unfortunately, I don't have FOSS or FOSS-B available in my lab, but it's supposed to work very nicely. And one of your colleagues, Christina Vargas, who I know from Twitter and who is an Australian pathologist, who just very recently with colleagues published a nice paper about some of the unusual variants of inflammatory hemangioma, like Apache and some of those others, actually often have FOSS or FOSS-B. I've not read the whole paper yet, so hopefully I'm not getting it wrong. FOSS or FOSS-B expression, which kind of is a strong suggestion that maybe those belong in the spectrum of angiolymphoid hyperplasia with eosinophilia. Now, this is beautiful. Look at this. When you have a cellular vascular neoplasm, if you're struggling to decide if you're worried about the growth pattern or if there's infiltrative anastomotic channels or slit-like spaces or something like that, and you're worried about Kaposi sarcoma or angiosarcoma, sometimes one of the tools you can use is to do a vascular marker. And if you want, you can do it alongside a smooth muscle actin. And the endothelial cells in the vascular channel pattern will be highlighted beautifully. So here, this is not needed diagnostically. In this case, it was very straightforward, I think, on the H&E. But for teaching purposes, I thought this is a very beautiful example of what looked quite busy at first on H&E and now is very organized, very well-formed vascular channels. It also can help highlight like the lobularity. And even though there are a lot of vessels scattered around in the background, they're all really well-formed. They're not infiltrating and invading and anastomosing like an angiosarcoma would. They're not solid cellular sheets. They're not infiltrative spindled areas. They're well-formed vessels and with a vaguely lobular architecture here, some dilated kind of feeding vessels and then smaller compressed vessels where you can barely make out the lumen because the endothelial cells are so closely compressed together. And what looked very cellular, actually, it turns out, is because there's a lot of background pericytes and histiocytes and lymphocytes and other cells in the background, probably fibroblasts and myofibroblasts, all of those things in the background that are imparting an appearance of cellularity, but it's not all endothelial. I would also like to point out on this CD31, the background blushy kind of granular staining that you're seeing, those are not endothelial cells, those are histiocytes. Histiocytes normally stain with CD31, but it's kind of a weak granular staining that is much weaker than the background endothelial cells. These are endothelial cells, blazing, level 11 positivity, and then the background maybe level 3 granular positivity, those are histiocytes. So in general, if you're looking at a lesion and you're wondering, well, I see some CD31 or I see some patchy erg staining, and you're wondering, is it enough to be an angiosarcoma or to be a vascular tumor? If you have to ask yourself if it's enough, the answer is probably no, because usually an angiosarcoma is going to be solid, blazing wall-to-wall expression with erg and CD31, okay? So we'll talk about that later in another case. Hint, hint. There, those are histiocytes. So beautiful example, and for contrast, ERG. Now, I love ERG. It's a very sensitive marker, but it's not specific. It tends to be a bit cleaner than CD31 and CD34. And I've got a little write-up on Kiko about how I use vascular stains and what their pros and cons are. One thing, though, that I really like about CD31 in a setting where you're trying to see the pattern is it's got such strong, crisp, membranous, and cytoplasmic staining that it really draws a dark line around each vascular space. Whereas ERG, you get mostly nuclear staining with some blushy cytoplasmic staining. It's not quite as crisp and pretty at drawing the outline of the vessels. So if I want to rule out angiosarcoma, I love ERG in that setting. It's really nice. If I want to see the vascular pattern, I think that sometimes CD31 works a little better for that. Or CD34, although there's some caveats to 34, which we'll talk about later. All right, so I just thought that was a nice treat for your eyes to see the stains there. And this is ALHE. And as you know, it's benign, but it can be multifocal or multinodular, and it can recur locally. So it's not uncommon for it to be kind of multinodular in the skin or the underlying soft tissue. And it's not uncommon for it to have one or even more local recurrences, but it's not going to behave in a malignant fashion. All right. I hope you enjoyed that case as much as I did. Now, case 9. And this is another amazing example. I should have put like some basal cell carcinomas in here so we could get through the cases in time. But case number 9. 30-year-old female with a 2.5 centimeter medial thigh nodule. On MRI, it was directly adjacent to the femoral artery and vein. So the differential was between a nerve sheath tumor or maybe a vascular malformation on imaging. But intraoperatively, the surgeons realized, no, this is not next to the femoral artery and vein. This is actually inside the lumen of the femoral vein. And that's what we're seeing right here. Here's the thick muscle layer around the outside of the vein. And we can see that the intima of the vein is pretty thickened here and reactive. There's kind of fibrosis and myxoid or mucinous change, which is what we see in kind of intimal fibrosis in vessels. And then the lumen itself is actually mostly plugged by a nodule of something. So at first glance, you could wonder, is this like an organized thrombus that's occluding the vessel lumen? I mean, there's blood, there's pink stuff that looks kind of, fibrinoid at first. But going closer, that's not all there is. It's actually not quite like bright red like fibrin, but in fact, it's more like kind of sclerotic to myxoid or even almost chondroid in appearance. So the word I would use for this background is a chondromyxoid, or maybe chondromyxoid / sclerotic collagen background. And embedded within that, we see epithelioid cells arranged as single units, small nests, or even little cords and chains in here. I think you may know where this is going if you've ever seen this tumor before. This is a rare bird, but this is a gold standard classic example of how this tumor occurs and presents. And it's one of multiple examples I've seen that look just like this. But these cells, I mean, they look epithelioid. You could think that they could be metastatic carcinoma, like metastatic breast cancer inside of the lumen of a vessel. That would be pretty strange to have that presentation, I would say. You could think of an epithelial tumor here, but that's not what's going on. And if we look around and see that this tumor, because it is a tumor, and I will show you what it is in a minute, is actually starting inside the vessel, filling the vein, and then perforating through the wall of the vein and invading the adjacent soft tissue. More of that chondromyxoid background here. There are reactive background vessels, but most of the tumor is actually epithelioid cells not making vessels. But you can see that some of these epithelioid tumor cells are actually making little vacuoles in their cytoplasm, kind of like the vacuoles we saw in the last case. There is abundant hemorrhage. Let's look closer at the vacuoles here. If we get lucky, you'll see that in some of those, we have little fragments of degenerated material, and occasionally you'll find inside those vacuoles erythrocytes. See here, we're getting degenerated fragments of erythrocyte inside the vacuole in these epithelioid cells. Here's another one. So these are the classic blister cells, which sometimes contain fragments of erythrocyte, and this, I think you've probably figured out, is a epithelioid hemangioendothelioma. All right? These are tumors, vascular tumors with intermediate malignant potential. And I want to mention right now, in case you're not familiar, there are several different types of hemangioendothelioma, all of which are totally separate, unrelated tumors. These are not just different morphologic variants of hemangioendothelioma. Hemangioendothelioma is not one thing with different patterns. It is multiple different things that get put into this intermediate category of not fully malignant like an angiosarcoma, but definitely not totally benign like a hemangioma. Some of them belong closer to the angiosarcoma side of the spectrum, and this is the one that does. Epithelioid hemangioendothelioma has the potential to metastasize and kill patients. It just doesn't do it as often or as rapidly as angiosarcoma usually does. And it molecularly is different from angiosarcoma, so it's definitely not a angiosarcoma either. It is its own kind of entity. These tumors were first, I think, described in the lungs and also in the liver, where they present as multiple nodules at presentation. And in those settings, a subset of the patients will eventually die from their disease, a significant subset, oftentimes many years after their diagnosis. So again, much slower and less rapidly progressive than angiosarcoma. And early on, people thought these were actually carcinoma because they were epithelioid cells, and they don't usually make well-formed vascular channels. What they do is they make these little blisters, these little bubbles, which is the cell's attempt to make an intracytoplasmic lumen. So it's kind of a immature vascular channel formation that never develops into full well-developed vessels that interconnect with one another, okay? So instead what you get are these little lumens with red cells or red cell fragments in them, and that's what you're going to usually see in epithelioid hemangioendothelioma. There is a rare subset that is an alternative fusion that can make vessels, but usually do not expect to see well-formed vessels. Expect to see single epithelioid cells or nests or cords or chains set in a sclerotic or chondromyxoid background. And these are going to stain with endothelial markers, and they often stain with keratin also, so beware of that. The classic time when they occur outside of the lungs or the liver, when they occur in soft tissue, sometimes they will arise in the lumen of a vein, and then they will expand and invade out of that vein into the adjacent soft tissue. And they can sometimes be centered in the subcutis or the dermis as well without involvement of a vessel. Here's another look where you can't really see the vessel wall, because this is kind of popped out of the vessel lumen here. But I just wanted to give you another look because it has some really prominent cords and chains here, if I recall. My computer's having trouble handling recording and loading all these web pages at the same time. There we go. That's the cords and chains pattern. And epithelioid hemangioendothelioma is one of multiple different tumors that can have cords and chains of cells. Myoepitheliomas can do this, chordomas, and a variety of others. So just keep this tumor in mind. And to show you, I think I do have the stains. Keratin was positive here, but to save time, I won't show you. I'll just show you, what was this one? I think this was ERG. Yep. Strong diffuse expression of ERG. So when these arise as a primary tumor in the skin or soft tissue in the periphery, I usually recommend to the surgeons that or the treating physician, that they do a workup to rule out an internal primary, because lung or liver primary epithelioid hemangioendotheliomas can sometimes metastasize to distant sites, including the skin or soft tissue. But here, this, I believe after workup, this was a primary arising in the vessel, in the femoral vein. And when they arise in the soft tissue, about 10% of those can eventually give rise to distant metastases, often in the lungs. So those patients do need follow-up, probably long-term follow-up, and they do need to have the tumor completely excised, ideally, if with negative margins, all right? And in this case, I did not do molecular because this was classic morphologically. But in difficult cases, you can confirm the diagnosis with molecular testing. The most common fusion is between WWTR1 and CAMTA1. And that was discovered several years back by a group of really great researchers. And so that's the most common finding in the conventional type of epithelioid angioendothelioma, and then the subtype, a small minority of cases have YAP1 TFE3 fusions, and that's the variant that tends to produce actual vascular channels. But look here, no vascular channels. There may be vessels in the background, but the tumor cells are making cords, chains, nests, islands with just vacuoles, not with well-formed vessels. So it's an important thing to know about, and remember that it's keratin positive often, just like epithelioid angiosarcoma can be. So you don't want to see epithelioid cells, do a keratin, and then think you're dealing with a carcinoma. Always keep epithelioid vascular tumors in your differential diagnosis when you're thinking of a weird carcinoma. Always think, could it be a vascular tumor? That's my advice. All right, a great example of epithelioid angioendothelioma. Now, case 10, a 20-year-old male with a thigh nodule, and it was excised. I don't have any other history. This is a very old case. Here we've got a nodule, or kind of multinodular proliferation here, growing in the dermis and the subcutis. Kind of infiltrative borders. And even from low power, we can see that these are large cells with abundant eosinophilic cytoplasm. Very dense eosinophilic cytoplasm. Almost, to my eye, almost kind of squamoid a little bit. They look almost like the cytoplasmic, density and texture of keratinocytes, The other thing that they might remind you of or make you think of, epithelioid cells with large nuclei and pale open chromatin, almost clear chromatin, and big nucleoli, and abundant cytoplasm that's dense eosinophilic is epithelioid sarcoma. Right away, if I see cells like this, I want to think of epithelioid sarcoma. I might think of a poorly differentiated carcinoma. I might think of other things as well. Maybe a reticulohistiocytoma even. I don't think there's any shame in thinking about that in the differential for a case like this. Some people have thought that these look like rhabdomyoblasts. Personally, I don't really think so that much, but there have been some authors that think that these look like rhabdoid or rhabdomyoblastic cells. Okay? So the other thing I want to point out here is that those cells looked epithelioid, but over here, the cells look more spindled, kind of elongated and spindled to epithelioid cells with large nuclei, kind of pretty atypical nuclei, but instead of being hyperchromatic, oftentimes this pale nuclear chromatin. And look in between, scattered neutrophils. That is a really helpful clue. It's not always present. I think about half of cases have this. But when you see that, that is a great clue for the diagnosis. So that's especially why I picked this case, because I thought it beautifully highlights the scattered neutrophils. Now, this tumor classically is going to be diffusely strongly positive for pancytokeratin, negative for CD34, strong diffuse positive for ERG, and oftentimes, I think about half or more of cases, strongly positive for CD31. And it would be negative for Desmond. So if you had any confusion about could this be rhabdomyoblastic cells, no. Desmond will be negative here. So I think hopefully if you know of this entity, it's quite rare, but if you've heard about it before, you'll recognize what it is. This is called pseudomyogenic hemangioendothelioma, aka epithelioid sarcoma-like hemangioendothelioma. And even though that name's a little more unwieldy, I actually really like that name because it really amplifies the fact that this tumor is easy to misdiagnose as epithelioid sarcoma. And some of the initial series on this, there were rare individual cases reported before, I think, but one of the first series was by Fulp and Billings, Fulp and Weiss, who described these as epithelioid sarcoma-like hemangioendothelioma because many of the cases in their series, in fact most of the cases in their series, were either misdiagnosed as epithelioid sarcoma or it was sent in consult and epithelioid sarcoma was one of the differential diagnoses. And you can imagine why. Strong diffuse keratin makes sense. And also keep in mind epithelioid sarcomas can be ERG positive, about half of cases. Like I told you earlier, ERG is a very sensitive vascular marker, but it is not specific. It can be positive in a variety of other things. Epithelioid sarcoma, prostate cancer, Acute myeloid leukemias are often ERG positive. It's actually a really nice marker for AML, in fact. And I've seen cases of AML with an unusual presentation in soft tissue that almost got misdiagnosed as epithelioid angiosarcoma. So please remember, if there's any doubt morphologically if something is a vascular tumor or not, if ERG's positive, great, but then consider maybe doing a CD31 or a CD34 also to help further prove that. Now, this tumor here is usually CD34 negative. All right, and it will be positive for ERG, like I said, and it's going to also have retained nuclear INI1 expression. So if you were having a debate about could this be epithelioid sarcoma, INI1, which I usually like to do to confirm a diagnosis of epithelioid sarcoma because the vast majority have loss of INI1. This tumor, pseudomyogenic hemangioendothelioma, or aka epithelioid sarcoma-like hemangioendothelioma, will have retained nuclear INI1, aka SMARCB1 expression. All right. So back to the story, though. These were originally described as epithelioid sarcoma-like hemangioendothelioma, and then Hornick and Fletcher later had another series where they suggested an alternative name of pseudomyogenic hemangioendothelioma, and that's the name that the WHO currently uses, but an acceptable alternative is epithelioid sarcoma-like hemangioendothelioma. Whichever name you like, just remember that depending on your point of view, it could look rhabdoid, or myogenic, or it could look epithelioid sarcoma-like, and it has a very unusual combination of markers. And you may be wondering, why the heck is this called hemangioendothelioma? There are no blister cells, there are no blood-filled spaces, there are no vascular lumens, nothing whatsoever to suggest that this is an endothelial tumor. So this is a tumor that we have to kind of believe, have extra faith in our immunohistochemical studies, because this is a tumor that is thought to be vascular because of its immunophenotype, because it expresses CD31 and ERG. Even though CD34 is negative, but it can be negative in vascular tumors sometimes, which is why it's not my favorite endothelial marker. In fact, it's my least, well, not my least favorite, but it's not my favorite. I like ERG and CD31 much better. But initially, this was thought to be a vascular tumor because it had ERG or CD31 expression, okay? And more recent studies molecularly, I think, are pretty supportive of this truly being an endothelial tumor, because these tumors often have fusion of FOSB and serpine genes. And let me look at my notes here to make sure I get the percentages right. The most prominent is serpine FOSB, but also an alternative fusion between ACTB and FOSB have been described. And FOSB and FOSB both have been described in a variety of different tumors, not all of them vascular, but a variety of vascular tumors, including epithelioid hemangioma / ALHE, like we talked about earlier, can have FOSB. And so here in pseudomyogenic hemangioendothelioma, FOSB serpine fusion or FOSB and ACTB fusion can be seen. So that, I think, is further support for the idea of this being an endothelial tumor, one that doesn't make vascular channels, strangely. There's another important thing I want you to remember before we move on to the next case, and that is that this is a tumor, and the reason that it deserves the name hemangioendothelioma, this is a tumor that often has multiple lesions. It's multifocal in about 60% of cases, and multifocal oftentimes within one extremity, like in the right leg, for example, or in the arm, okay? So it can be regionally multifocal, and those are thought, my understanding is that that our current thinking is that these actually represent regional metastases, but they don't often spread beyond that to have distant metastases. So they can be multifocal in 60%. They involve the skin in about 75% of cases, the muscle in 50% of cases, and the bone in 20% of cases. So that's from the WHO 4th edition. Reading those stats there. But I think it's important to remember that they can present as multiple nodules, often in the same extremity, and they often present in multiple layers of the tissue: dermis, subcutis, muscle, and even bone. And so if you look at these on like a CT or a PET CT, you're going to see multiple nodules in a region. It's going to look like multifocal metastases, which again is probably what it is. But this is not the kind of, that looks very aggressive on imaging and yet has very indolent behavior, and distant metastases or more aggressive behavior is actually quite rare. But there have been some that metastasize to the lungs. Okay, and the histologic features do not help us in predicting which of these cases will metastasize. But it seems like most patients have a good prognosis, but they do have multifocal disease that can be problematic to manage from a clinical perspective. Okay, so I think this is a really nice characteristic example of pseudomyogenic hemangioendothelioma, and again, totally unrelated to epithelioid hemangioendothelioma, totally unrelated to Kaposi form hemangioendothelioma. All of these get put into that intermediate, not fully benign, not fully malignant, but they are not related molecularly. They have different morphologic features. They are totally unrelated tumors. Okay. So I think this is a nice example of a rare bird, and keep in mind those neutrophils. Scattered neutrophils are a great clue for this, although unfortunately not always present. All right, the next one is case 11, which is an 80-year-old male with a pink crateriform papule on the nose, and the clinical impression was squamous cell carcinoma. And I wish I had the photo handy, but I saw it at the time, and let me tell you, this tumor looked like a squamous cell or a basal clinically. It was pink, it had a crater in the middle, a little bit of scale on top. I was shocked when I saw the path, and then I saw the clinical. Not at all what I expected the clinical to be. So hopefully you find this instructive. So this is a dense nodular proliferation, sheet-like proliferation of very dark blue to purple cells filling the dermis in an old sun-damaged individual on the face. And we've got ulcer, some serum crust on the top, dilated follicle with keratin in it, which I think may have imparted that crateriform appearance, given the false impression of what looked like a squamous cell carcinoma clinically, but turned out not to be. And I want you to pay attention here for a second, just to add a little extra terror to your day and give you something to have bad dreams about. This is the stuff nightmares are made of, because we have very ugly epithelioid cells with very atypical nuclei filling the dermis kind of in sheet-like configuration, with some areas having kind of almost a nested look. All right? And if you did a keratin here, I think this case had some weak focal keratin expression. SOX10 was done because right away I think I would think of melanoma in a case like this. I would think of poorly differentiated carcinoma. And I would think of one other thing, which is what this ended up being. And hopefully you thought of that too. I will come back and show you more morphology in a minute. But I just want to show you how if you have a biopsy, a shave, or that's shallow, or a partial biopsy from an area that's solid like this, you can really get burned and miss the diagnosis. Especially in cases where there's strong keratin expression, you can misdiagnose this as poorly differentiated carcinoma. Let's see here. I'm going to open up the immunostains. I believe this was the CD34. And it's pretty much, once it comes into focus here, I mean, practically negative in most of the tumor. And that's why I included it, so you can see the background vessels are, sorry, I think I've overtaxed my computer again. There we go. Background vessels are positive, tumor cells negative. For the most part, there are some focal areas where we get some kind of weak to moderate, patchy CD34 expression, but it's mostly negative. Try to reload that one. Sorry, I hear my computer's cooling fan whirring madly and rapidly down under my desk, trying to keep the computer cool from the recording and all the digital slides. Oh, guess this happens sometimes. All right, here's the keratin. It was mostly negative, but there was some weak focal staining here and there. But I would say that this tumor can sometimes have strong keratin. Here's some kind of blushy keratin. But ugly epithelioid cells in the face of an old sun-damaged person and some keratin, you might be inclined to call this a carcinoma if you're having a bad day. But let's go back and look at more morphology. One thing that helps me is this color. This is this bluish purple, kind of purplish color, or slate blue gray color, or amphiphilic, whatever name you like for this color here. When you see that, it is always makes me think of this diagnosis. And if you're lucky, on a big enough biopsy, if you look around, you're going to start to see the vascular channel formation with ugly, hobnailed endothelial cells protruding into the lumen. You may see interconnected anastomosing channels in some places. But as you probably figured out, this is angiosarcoma. Epithelioid angiosarcoma with many solid sheet-like areas and nested almost or nodular areas. Look at that nesting right there. Look at that. And I think that part of how this nesting occurs is that vascular lumens, malignant vascular channels, get filled up because of multi-layering of the tumor cells, layer on top of each other and eventually fill up the lumens and make these filled up vessel spaces that actually are mimicking nests, okay? So I think that's important to remember that sometimes angiosarcomas can do that. And I've seen them mimic carcinoma, mimic melanoma. Sometimes they can be more spindled and mimic AFX or polymorphic dermal sarcoma. But here, if you looked around the slide enough, it should have been, with practice, this is pretty easy to tell, oh yeah, this is an angiosarcoma. But I just want you to see how scary it can be if you had a partial biopsy, because you sometimes see no vascular channels whatsoever. So when I have a pleomorphic spindle cell tumor that I'm thinking of a sarcoma, or a really ugly epithelioid tumor, and I think of poorly differentiated carcinoma or some sort of epithelioid, a sarcoma with epithelioid features, I try to always include ERG or CD31 in my panel just to make sure I avoid missing an epithelioid angiosarcoma. And unfortunately, these are very aggressive tumors like most angiosarcomas are. And I think this slide right here, the color is a little different because it was a recut that was stained a different day. I think got put on a different stainer, or the stain needed redone or something. But in any case, you can see again there are vascular channels in here, but they're pretty focal, and you got to go look for them. All right. Now let me show you the vascular markers just so you believe me. Thank you for your patience while I load my slides here. So this one is a nice, crisp, cytoplasmic to membranous stain, and it's also highlighting background histiocytes, so this must be CD31. And CD31 shows diffuse, strong expression in the tumor, and so does ERG. So I've never personally seen an angiosarcoma that was negative for ERG or negative for CD31. I'm sure if I do this long enough, eventually I'll encounter one. But I've seen multiple angiosarcomas that were negative for CD34. So the real lesson I want you to get from this case is, number one, solid, ugly epithelioid cells with nesting, with a kind of amphiphilic or blue-gray or purple cytoplasm. Think of epithelioid angiosarcoma. Hunt around for vascular channels. Sometimes they're very focal, sometimes they are absent if you don't get a big enough biopsy. Usually if you have a big biopsy or complete excision, you will find some vascular channel. Look at those hobnailed cells. And remember, hobnailing can be seen in angiosarcoma, hobnail hemangioma, rediform angioendothelioma, and others. So hobnailing by itself does not mean malignancy, but ugly atypical hobnailed cells that are starting to pile up and this is some multi-layering right here, look. You should usually have one endothelial cell layer in a normal vessel. But here, look at this. They're piling up and filling the lumen right here. And that's how, if that keeps growing, that's how we get those nodules that look like nests when that fills up the lumen. Really good example there to see that happening in action. And also look what's happening here. Background derma is probably normal vessels here. They're getting completely wrapped by malignant endothelial cells. That's the way angiosarcomas grow. They divide the dermal collagen and wrap around it. They wrap around adnexal structures and eccrine ducts. They're really infiltrative and anastomotic channels. Good example. But just remember that CD34 is often negative, or may be negative, particularly in epithelioid angiosarcomas. I've also seen it in conventional angiosarcoma that had no epithelioid component, dead negative for CD34. So I do not like to use CD34 as a screening marker for vascular tumors because of cases like this one. Even though there is some patchy staining here, I've seen several others that were completely dead negative. And if you use CD34 alone to rule out vascular, you're going to miss the diagnosis there, and you're going to call it AFX or something else and not recognize that it's an angiosarcoma. And these are, pretty aggressive. They have some unique clinical and treatment considerations, and it's really important to recognize angiosarcoma. Good example. All right, a few minutes late, but not as late as last time. So let's do the last case, and this is case number 12. I was hoping to be in Australia in person, and, COVID stole that from me. It stole several other very nice trips from me, but I was really looking forward to Australia. And I thought, hopefully, if I do a good enough job on this meeting, I'll get invited back. But after going overtime on every lecture, maybe I won't get invited back. So, oh well, I hope you guys at least enjoyed yourself, and can forgive me for talking too much. It's been a problem my whole life, and if it hasn't changed after 40 years, I suppose, it's probably not going to change ever. Now, this is a deep intramuscular nodule in the calf of a 20-year-old male, and this is a tumor that does not often occur in the skin, but it can. I actually not long ago saw an example in the subcutis, and so it's important, I think, for dermpaths to know about for a couple reasons. As you can tell, this is nowhere near the skin because look at these. These are nerves. And if you're a dermpath that dermatopathologist that only does dermatopathology, or you're not a pathologist by training, you're a dermatologist by training and have not seen a lot of pathology, you may not often see massive nerves like these. Big nerves that have obvious axons surrounded by myelin and big thick layer of perineurium around the side. This is not like a little branch of a nerve in the subcutis. This is a central nerve bundle deep down in the muscle with multiple branches of the nerve here present, okay? And in the midst of this bundle, growing in a branch of one of these nerves, I will show you on the next slide, we have a tumor. Ugly epithelioid cells making a big nodule, nest-like areas, or cords and chains in some areas, little nests in others, sheet-like areas in other places, ugly atypical cells. So I wanted to show you this slide so you can see how it's centered right in the middle of a nerve bundle, deep, deep down away from the skin. And then this slide, I think, shows, you can see the nerve bundles here as well. And look, when it comes into focus here, nerve wrapped around by tumor. Tumor is surrounding this nerve inside the perineurium, like perineural invasion, okay? And in this case, the tumor is actually arising from the nerves and expanding outward and making a big nodule. And this case is classic. I saw another case, the one actually I mentioned that not long ago I saw one in the subcutis, and it was growing off of a nerve just like this, a bit smaller, but it was probably some sensory branch coming up into the subcutis, and the tumor was growing off of it. And here, the tumor cells have kind of cords and chains and nests, and they're very atypical. Sorry, I'm waiting for it to come into focus. Maybe I'll go back to the other slide while this one freshens up, so you can see the cytologic features. These are nasty, ugly cells. In fact, they look quite a bit like that epithelioid angiosarcoma I just showed you. It just goes to show that malignant soft tissue tumors with epithelioid features can have a lot of overlap cytologically. Epithelioid sarcoma, particularly the proximal type epithelioid sarcoma, which I did not show you today, and is on a spectrum with rhabdoid tumors. Those can look similar to epithelioid angiosarc, which can look similar to epithelioid sarcoma like hemangioendothelioma, and others. And also, of course, melanoma could look like this, right? Ugly atypical epithelioid cells making nest-like structures and sheets and having abundant cytoplasm. This could easily be a metastatic melanoma. But in a young patient with no history of melanoma, I think it would be really unusual to have a big nodule of deep metastatic melanoma right around a big deep nerve as a solitary lesion in a patient with no history. Is it possible theoretically? Yeah, of course. Is it statistically likely? No way. So that's important here because if you do stains, this tumor here is strongly diffusely positive for S100 and SOX10. Negative for MART1, negative for HMV45. but it's going to look ugly like a melanoma, cytologically like a melanoma, strong diffuse S100 in socks like a melanoma, but it's going to usually be arising in a big nerve in a patient with no history of melanoma. So that's really important. When you see that setting where it looks like a metastatic melanoma, but it's wrapped around the nerve and the patient is young and has no history, particularly in that, or it's coming off of a big, deep spinal nerve root, think of this tumor, epithelioid malignant peripheral nerve sheath tumor. So even though this is epithelioid MPNST, it actually is quite different from conventional spindled malignant peripheral nerve sheath tumor. The conventional spindled form of MPNST is different clinically, molecularly, and immunohistochemically. Both of them are tumors that arise from nerves, but they seem to be totally different from one another in most ways, okay? So I really think of them as two separate tumors that are malignant and arise from the nerve, rather than like a variant, even though they are classified together as under one heading in the WHO book. I really think they're quite different, okay? The conventional spindle type of tumor, of malignant peripheral nerve sheath tumor, arises often from neurofibromas, oftentimes arise in patients with neurofibromatosis type 1, and is usually going to be paradoxically negative for S100 or SOX, or have only weak patchy staining, and it'll have loss of H3K27Me3 expression in many cases. Now that's the conventional spindled form, but the epithelioid form that I'm showing you here almost always has strong diffuse S100 and SOX10, so it's really easy to get mistaken for melanoma. All right. It does not usually have loss of H3K27, and it does not have an association with NF1. So totally weird and different. And this is one that's going to look and stain like melanoma, but not make sense to be melanoma clinically because it's a deep nodule arising in a nerve. Okay. So what can you do to sort it out? Well, aside from the fact of looking at the clinical history and finding it wrapped around a nerve, one other thing that you can do is test this for INI1 or SMARCB1, which is lost in the majority, about 75% of cases of epithelioid MPNST will have loss of nuclear expression of INI1. I don't think I did it in this case because it was so clinically, and I unfortunately don't have a picture to show you. But the case I saw not long ago in the subcutis, it actually had diffuse loss of INI1. So a reminder that INI1 loss is not only seen in epithelioid sarcoma, it could be seen in a variety of other tumors. So really important to remember that, okay? But it's really helpful here in the setting of a tumor that looks like a melanoma, but is around the nerve, has strong diffuse S100 and SOX, negative MART1, and has loss of INI1. That's classic features for epithelioid MPNST. So why am I showing this to a dermatopathology meeting? Well, usually it will arise deep, but sometimes it can be in the subcutis, in which case it could easily get sent to you as a dermatopathologist. Also, anytime, if you're in a practice with other pathologists that don't do Dermpath, and they see something that they think is ugly and looks like melanoma and stains with S100, you better believe they're going to show it to dermatopathology in consultation and say, hey, could this be metastatic melanoma? Doesn't matter where it is in the body. I feel like if you're a Dermpath, there's a good chance someone's going to show you a case anytime they think it might be metastatic melanoma, and it's important to remember this. I think that these tumors can easily get confused with melanoma. Conventional MPNST, the spindle form, people think that it looks or stains like melanoma, but really it does not, okay? If you see something in the skin that's ugly and spindled and strong S100 positive or SOX10 positive, it's on the scalp of an old person, do not think that that's going to be spindled malignant peripheral nerve sheath tumor. Heck no, that's going to be spindle cell melanoma until proven otherwise, all right? Because you do not have strong diffuse S100 or SOX10 in the conventional spindle form of MPNST, almost never. All right, if you want to learn more about conventional MPNST, I have a whole long, like hour-long video of it on my YouTube channel, and you can learn more about that than you ever wanted to know. But that tumor almost never occurs in the skin. Epithelioid MPNST sometimes does, and is much closer mimic to melanoma, in my opinion. All right, I think that brings us to an hour and 2 minutes, so only 15 minutes over this time. I'm really sorry, but I hope that the cases were worthwhile. And thanks again for letting me share them with you and for inviting me to be present with you virtually in Australia. Have a great day.